We have an exciting panel today talking about what training might be needed to administer anesthesia in space. As more people go into space for longer periods of time, it's almost a certainty that one will need anesthesia for surgery in the near future in the space environment prior to returning back to Earth. So today we have talks that lead towards, hey, what training might be needed for non-anesthesiologists to administer anesthesia in space, given that it's not certain that an anesthesiologist will be present for every space mission. We'll have Keith Ruskin talking about some human factors and systems issues as well as equipment, Dr. Michael O'Connor talking about Airway, Robert Fong talking about medications and pharmacologic issues, Fayyaz Ahmed talking about regional anesthesia, very exciting topic and very likely the wave of the future. Arthur Formanek about avoiding air embolus, and finally, I'll be talking about vascular access. So to start, Keith Ruskin, MD, is a professor of anesthesia and critical care and director of aerospace medicine at the University of Chicago. His clinical practice focuses on neurosurgical anesthesia. His major academic interests include neurosurgical anesthesia, human performance, and aerospace medicine. His career has focused on teaching these disciplines to practicing physicians. Keith has worked as part of a team to develop guidelines for screening morbidly obese pilots for obstructive sleep apnea and for the management of in-flight cardiac arrest. He has developed a fatigue risk management program for physicians who must work overnight shifts and participated in a NASA workshop on space torpor. Keith is also interested in the terrestrial applications for this work, writing articles on the role of automation in the operating room and how personal protective equipment affects human performance. His funded research involves developing guidance for the next generation of alarms, alerts, and warnings in air traffic control. He has many other accolades as well, but in order to not take up too much of the time of his talk, I'll let you continue, Keith.
Thank you. All right, well, thank you very much. Let me share my screen here. Some of the factors you'll have to worry about during surgery, during long duration spaceflight is isolation, limited resources. Once you're on your way to Mars, you can't turn around and come back. You also have to worry about microgravity. So it's impossible to remove air bubbles, or very difficult to remove air bubbles. We'll talk about that in a second. Both the patient and caregiver have to be restrained. If you're going to do a general anesthetic, you've got to worry about airway management. You've got to worry about what drugs and equipment you're going to bring. There's no gas scavenging, and any volatile agents you use are going to be vented into your vehicle. And all this relies on equipment that's big and heavy, meaning it's very expensive to launch into orbit and then very expensive to take from low Earth orbit onto wherever you're going to go. And even after you've successfully done the procedure, you have to maintain this patient now recovering from a procedure. So you have post-surgical and post-anesthesia care. This has been done before. One of the first surgeries to occur in an austere environment in modern times was a Soviet surgeon who had to remove his own appendix during a winter over in Antarctica. So it has been done before. And that leads to the question, if you're going to be sending people to space for a long period of time, should you remove their appendix and gallbladder preemptively just to minimize the risk of having a problem during the flight? But the problem is that anytime you do surgery, you increase the risk of any complication, in particular small bowel obstruction. And so Rays et al. Did a probabilistic risk assessment, essentially using a Monte Carlo methodology, to determine the possible benefits of prophylactic surgery. And what they did is they looked at the risk of appendicitis or cholecystitis during a hypothetical 2.5-year Mars mission in otherwise healthy people. And what they found is that if you remove these organs before flight, you increase the probability of some kind of medical problem. If you didn't remove the organs, you had a slightly higher risk of crew loss of life. But if you did remove the organs, they were more likely to need a procedure later on. So the conclusion of the study is that you probably don't want to do unnecessary surgery. And hope they don't need surgery during flight, or if they do the surgery during flight. So let's look at what they have on the International Space Station. There are two packs that are sent. The Advanced Life Support Pack, which has medical equipment and supplies for advanced life support. Basically, the goal is the care and stabilization of a critically ill or injured crew member, and you want to stabilize them until you can get them back to Earth. The organization of this thing is that you've got a large case, and then equipment is designed, and medications are organized into sub-packs, pockets, and compartments, generally so that things you would need at the same time are packaged together. The pack has a yellow reference card that gives a non-medical crew member instructions on what to do with this thing. There's also an ambulatory medical pack, which has medical supplies for routine issues, mostly the diagnosis and treatment of minor illnesses like an upper respiratory tract infection or ear infection, GI upset, things like that, and minor injuries, something that would happen that you can treat on orbit. There's also a portable clinical blood analyzer that you can use to get laboratory tests if you need it, and oral and topical medications, bandages, things like that. And the pack is organized the same way, with equipment and medications that you would tend to need at the same time packaged together, and a reference card explaining how to use everything. There's no requirement now for a physician crew member on the ISS. Sometimes there's a physician if they're doing that kind of research, but there may not be. Now, as we plan longer and longer missions farther away from Earth, you probably will send a crew member. But the question is, what kind of training should that crew member have, and what should their specialty be? Should you send an anesthesiologist? Should you send a surgeon? Should you send an emergency medicine physician? And this is the topic of a lot of debate right now. But even so, even if you have one medical crew member, oftentimes you're going to have other individual crew members delivering care, either through telemedicine in low Earth orbit or to the moon, but potentially autonomously during a trip to Mars, and with only the training they received on Earth, or maybe supplemental training while they were on the vehicle. So ideally, you want to use human-centered design principles for all the procedures and equipment you do, and the equipment has to be easy to use and ideally packaged and designed in a way that guides crew members through the procedures that they're going to be doing. Some potential things to look at include labeling of the equipment, location of the equipment. So the ISS, again, has two packs, an emergency pack and a routine pack, and then the co-location of the items, placing them where you would most likely look for them. Clear presentation of information. And Barbara Burian, actually, from NASA, recently studied a telemedicine information system for autonomous crew members. So telemedicine if you're in low Earth orbit, and then presentation of information, of pre-stored information, or something you could send up all at once on demand. You also want to design the equipment to prevent errors in its use. You need to place the equipment where it can be used, and all that leads to fundamental understanding of human factors in the design of this equipment. Some other considerations are that, again, everything is very expensive to get out off the Earth. So you want to minimize the mass and volume whenever you can. You want to minimize the power requirements as well, because again, you have a limited amount of power in any space vehicle. Now, currently the ISS, the equipment is managed on the ground. Whenever crew members are flown up, they're flown with fresh medical kits. You can replenish medical kits on routine supply missions, but this is only feasible in low Earth orbit. As you move farther away from low Earth orbit, you're going to have to manage this equipment in flight. So that means you're going to need to have all of your equipment have a long shelf life. You want it to be resistant to radiation. You need it to be stable at whatever temperature and humidity is there in your vehicle. Space vehicles tend to have a higher partial pressure of carbon dioxide. So you want the equipment to be stable at that higher partial pressure of carbon dioxide. And you can't get a clinical engineer so you want to have the equipment easy to maintain, and you need to train the crew members to maintain and to use this equipment. So all that plays into the fact that you, again, need to have intuitive designs for people who aren't going to be using this a lot and may not have medical training. And this is especially true for equipment and drugs used for cardiac resuscitation. In case you're curious about how you would do CPR, this is one way to do CPR. This is a test of some astronauts on the International Space Station. They've got a crew restraint system on the bottom, and we'll hear more about that later. And rather than trying to do CPR kneeling on the bedside, the crew member, you can see, has braced his feet and his socks up against the opposite side of the space station, and is using that to give him a perch to provide CPR to a pillow in this case, and they were gauging the effective chest compressions. So how do we know what kind of training and equipment we would need? This is a fascinating study published last year where a group of surgeons and anesthesiologists deconstructed a laparoscopic appendectomy. They did a hierarchical task analysis, and the goal was to see if they could train a non-surgeon to do the procedure successfully. So they analyzed the action, skills, equipment, and supplies needed by an anesthesiologist, a surgeon, and an assistant. And then they also looked at what items would need further study in microgravity. After that, they did a scoping literature view, and this led to a multi-column spreadsheet with links to instructional videos. And an expert review then looked at that. Experts then reviewed the spreadsheet for gaps and inadequacies and compared the procedures as described on the spreadsheet to a pre-recorded procedure on actual patients. This was then used to test this, to develop a simulation that was used to test this task analysis. They ultimately found 2 minutes. 178 lines and 13 columns were needed. There were 8 action sequences that were identified as generalizable, and there were 27 items that were identified as multi-purpose, but non-medical people were able to perform a successful laparoscopic appendectomy using 30 items. In terms of what kind of surgical equipment, what you'd be doing during surgery, you need to have airway management equipment. It's difficult to remove air from fluids in microgravity. I can discuss that further during the question and answer session. You also need infusion pumps and specialized administration sets. This is an example of a crew restraint system that has straps that you can use to hold the patient to that, and also footholds and handholds for the healthcare providers. Most of the equipment you would need would be made on site using 3D printers. And here's a quick, here's a study where a group of non-medical personnel in an austere environment was able to 3D print surgical instruments and perform simulated surgical tasks on mannequins with these 3D printed instruments, with basically just training from pre-recorded videos. Interventional radiology and ultrasound is a potential procedure that a potential way to treat surgical emergencies, but we won't. I'm running out of time, so we'll talk. Just mention regional anesthesia. With ultrasound equipment, you need training for on the use and the procedures there. And I will stop there. Again, I'm sorry I had to rush a bit, but thank you very much for your time.
Thank you so much for that outstanding talk. Next up, we have Michael O'Connor, MD, talking about Airway. He's an anesthesiologist and intensivist at the University of Chicago. So he's clinically active in both the operating rooms and the intensive care units. He serves in a variety of administrative roles for both the university and the hospital. His research interests have included sedation in critically ill patients, new drug development, brain function monitoring, blood substitutes, airway management, predictive analytics, and human factors. He is also the vice chair for academic affairs for our department, and I know he's received many national awards for critical care as well through his involvement in societies. Go ahead, Michael. Thanks so much for speaking.
Well, super. Thank you so much for inviting me. I'm going to make those auctioneering lessons pay off. So I have no conflicts of interest related to this talk. Nobody would pay me to give it. There's a substantial literature about all sorts of things related to medicine and space. It includes some thoughtful analysis, review of healthcare events in spaceflight thus far. Keith mentioned a couple of them. Lots of simulation experience, and even guidelines have been written about this. Really, the 3 things that shape a lot of the care that we generate, especially airway management in space, end up being physics, particularly zero gravity, Newton's laws, and cohesion. And we're going to explore those and how they shape what we can and can't do with respect to airway management in space. So the first thing I'd like everybody to know is that, Nash is imagining a 6-person crew on a 900-day mission. And, they basically said that, if we actually do this, if this actually comes to fruition, we may be up to 1,100 days, right? And, as you go further out in space, the time delay associated with radio contact with Earth, goes from 4 to 20 minutes in each direction. So you can imagine there's no holographic doctor that's going to guide you if you can basically exchange words every 40 minutes. In terms of the epidemiology, the risk of a serious medical event is supposedly about 0.06 per person year of flight, which corresponds to about 1 event per 2.8 years for a crew of 6. That is to say, you're likely to have 1, you might well have 2. If you're really unlucky, you could have a lot more. Interestingly, it's actually safer to be in space than it is to be a person on the planet. But of course, NASA has to make some guess as to what it wants to engineer in terms of the safety margin. And this is what Komorowski wrote about the margin that was engineered in 2016. I don't know if that's correct, but that's what they have. A couple of things to know. A bunch of things that are very Earth-like can happen on space, including trauma, infections, cardiovascular disease, kidney stones, people going crazy, cataracts, and cancer. And some very space-specific conditions, cardiovascular conditioning, which we're going to talk about in just a second, radiation exposure, vision impairment, and ICP syndrome, hypobaric decompression if you have any kind of a leak in the space station or in your spacecraft. Any toxins that make it into the environment can make it into the atmosphere. Problems with temperature regulation, and of course, if you make it to the planetary gust. A lot of our physiology is in fact related to having an adequate circulation in the face of gravity. And so it's interesting that a lot of the changes that happen in space come as the physiology of adaptation to postural position at 1 gravity atrophies. And so this is a very nice figure from Komorowski's article. And you can see that it takes about 6 weeks for most of your physiologic adaptation or adaptation to a physiologic to 0 Gs. Your heart rate is initially slow and then it becomes normal. Your blood pressure is initially down and either goes down or stays down. Remember that we have such a high blood pressure because, in fact, we want to stand up and still perfuse our brain. Your central venous pressure either stays the same or, interestingly, goes down. Once again, you're in a 0 G environment. Your blood volume typically goes down 9 to 17%. That has implications if you have any kind of trauma. Your intracellular fluid goes up. That is, say, all your tissues swell, and we'll talk a little bit about that later. Cardiac systolic function is preserved. Diastolic function goes down. Your SVR goes down because, once again, one of the reasons why we have such a high SVR is to maintain the blood pressure we need to perfuse our head in the face of gravity, and we don't face that in 0 Gs. The baroreceptor reflex atrophies as a consequence of that. Because you're not exercising at full tilt, almost everybody's exercise capacity goes down. In terms of the pulmonary physiology of space, basically we see rapid, shallow breathing, a slight decrease in the tidal volume, vital capacity, which translates into a slight decrease in the forced vital capacity. The peak expiratory flow goes down just a little bit. The functional residual capacity goes down pretty much in proportion to the total lung capacity. So getting on to the specifics of airway management for the first 5 minutes, or for the next 5 minutes, this is a normal human in pre-flight, and right here, this is the pressure in various places in the body. And in microgravity, what happens is the pressure is equal everywhere. In fact, you don't have a lot of pressure down here. Because you're not walking around a lot, you get what we call bird legs. So there's much less blood flow to the thighs and the calves. And because the intracellular water goes up everywhere, interestingly, people get very puffy faces in outer space. And so when you look at people's photographs from the space station, if they've been there for a long time, you'll see that their faces are actually kind of puffy. They look very different. And of course, when they go back to Earth, their baroreceptor is poisoned, and so it struggles to perfuse the brain. They have what we call chicken legs. That is to say, they have atrophy in the legs here, and it takes a while for those to recover. We rely upon gravity when we think about managing patients to keep the patient and their head on the table. And of course, that's not a help to us in outer space. We're at 0 Gs. We actually count on gravity to keep us in place as we leverage the airway with a variety of maneuvers that we do. And we, of course, rely upon gravity to keep secretions pooled. And unfortunately, there's nothing we can do to offset that particular problem. This is a bottle of intravenous fluid in outer space, and you can see there are a bunch of bubbles here, which is going to be perhaps a risk for air embolism that somebody else is going to talk about later. But you could just imagine that the exact opposite would happen. That is, say, if somebody's got an aerosol of secretions in their mouth, they'll pretty much have a cloud of secretions in their mouth, which shapes a lot of what we do. Keith kind of alluded to this in his conversation, or in his presentation. Here's an example of somebody who's planning to intubate this mannequin in a zero-G environment, and here's their assistant who's going to provide cricoid pressure or observe them, and this person's got a laryngoscope. But of course, Newton's laws apply, and when Newton's laws apply, all sorts of things happen, one of which is the observer who might, if they're not really well anchored, the leverage that they use often will produce a situation where instead of lifting the jaw up, they will go up. And of course, when that happens, they don't have a line of sight to the larynx to put the tube in. And their assistant, who may be able to stand and provide adequate cricoid pressure, their head position doesn't matter, but this person's head position does matter. Next up, people have tried to solve this. And so here's an example of somebody solving this by trying to intubate from the side. So they've got their grip on their subject's head, they're bracing themselves on the side, and they're going ahead and intubating here. This is what I call the neck breaker. This is not something you would do in a variety of contexts, not the least of which is somebody who has a traumatic injury to their neck, right? This would be the end of the game. So we don't really even have an easy way to deal with the mechanics of putting an endotracheal tube or a breathing tube in the windpipe of a patient. And people have studied kind of direct laryngoscopy versus video laryngoscopy. And the expectation was that video laryngoscopy would be better because you need a lot less leverage to put the tube in. And here's an astronaut or somebody in a zero-G environment using one of those video laryngoscopes, one that's very common use and probably the right one to pick for space, right here to go ahead and put a breathing tube in. And so once again, video laryngoscopy associated with a higher intubation success rate and speed, higher confidence for correct tube placement by novices and microgravity, and maybe the best way to deal with this. There are some GI issues we need to think about as we deal with this in space. One of which is there's no secretions in these simulators, and anybody who's sick may well have a cloud of secretions, a continuous cloud of secretions coming from either their tracheobronchial tree or their GI tract. And the first thing that happens is the camera goes down in your video laryngoscope because the camera is very small. And of course, these mannequins don't have puffy faces. All of the patients will have airway edema. And video laryngoscopy fails in the face of secretions. Of course, when we intubate people, if we're intubating somebody in an emergency situation on the space station, they may have a full stomach, in which case they may have some emesis. And that's not a pleasant experience because, once again, no gravity means it goes everywhere, and you're trying to fly an endotracheal tube through a cloud of emesis. As Keith has kind of alluded to, there's really no possibility of long-term ventilation or even advanced life support in outer space. So it's likely that one of the things, the airway appliance of preference in outer space will be a device called the iGel, and that's a device that has a curve that looks like this. This is what one looks like in a patient. This is, the most likely size that you would use in an astronaut. And this is just kind of a diagram from the vendor of all the features of this. The advantage to this is, of all of the devices we use, this is the one that amateur operators have the greatest chance of success in terms of inserting it. You can use this to generate a little bit of positive pressure ventilation in patients. And you've got the advantage that it could be reusable, although they're not designed to be. They're light. And they're perfectly appropriate for short-term use. Like I said, unlikely to be anybody who's going to survive long-term mechanical ventilation in space. So finally, I will leave this with you. This is what emesis looks like in a spacesuit. We see this sometimes, particularly in the first several days in orbit. It's not pleasant. You could imagine that trying to fly a video camera through that would be really hard. And of course, this is an astronaut from EVA 23 on 16 July 2013. This is somebody who almost drowned in their helmet because of a problem with managing the actual humidification of their airway secretions. And with that, I will stop. I've touched on the issues, and I can't wait to hear the other talks.
Thank you so much for that outstanding talk, Michael. Really, really informative. Really appreciate it. So next up, we have Dr. Robert Fong. He received his undergraduate training at New York University and his MD and PhD degrees at the University of Chicago with graduate thesis work in biochemistry and molecular biology, focusing on the study of autocatalytic RNA molecules and development of technologies to detect post-translational mRNA modifications. He did his residency at University of Chicago as on the faculty. Currently, he's an associate professor and director of the Anesthesia Perioperative Medicine Clinic. His area of research is related to basic science investigation of anesthetic mechanisms and development of strategies to accelerate emergence and recovery from general anesthesia. And he's the director of the Anesthesia Board Prep Program for the Dana Miller Healthcare Education. And today, Rob will be talking about anesthetic pharmacology in space.
All right. Thank you for the opportunity to speak here. I also have no disclosures to report. And so as we talk about administering anesthesia in space, this talk will bridge some of the other topics that have come before and will come ahead of me. Ultimately, the focus will be getting toward what kind of drugs might we use to perform anesthesia in space. And so some of you may remember seeing this movie, Prometheus. It was sort of the prequel to the Alien series, and a very memorable scene in the annals of science fiction movies was the C-section that was performed in this medical pod where they birthed an alien out of her belly. And in that scene, you see that anesthesia is performed basically by spraying something over the incision site, within the pod, and then, cutting out the squid-like alien there. That's not exactly the way anesthesia is done now with our current technology. And so let's drill down a little bit about what we mean by anesthesia. So classically, we think of anesthesia as encompassing four aspects: lack of awareness, analgesia, because typically we're doing things that are very painful, amnesia, a very invasive surgery can be very traumatic if a patient has memory of what's going on. And then this is more for the proceduralist than it is for the patient, but a lot of times, depending on what the surgeon is doing, you may need the patient to be still and immobile. So it turns out that the individual anesthetic that you use for a particular procedure is largely customized. And rather than thinking of each of these elements of the anesthetic state as a binary aware, not aware, analgesically managed or not, you think of them as sort of sliders, right? There's a continuum of awareness, amount of analgesia, amount of amnesia, and amount of neuromuscular paralysis that you need to provide. And the key to crafting anesthetic, as we do it here terrestrially, is that there are different categories of pharmacological agents that are best at providing each of the aspects of the anesthetic state, and we leverage combinations of them to position our patient along a certain predetermined position on the slider of each of these aspects of the anesthetic state that gives them the safest and best experience for the particular procedure that they're having. We then talk about a continuum of an anesthetic state that ranges from minimal sedation all the way to general anesthesia. And again, you want to think of this as a continuum rather than as discrete states. In other words, as I increase the amount of an anesthetic that I administer, I sort of gradually progress from minimal sedation through to moderate sedation through to deep sedation. And the key sort of aspects of defining those states have to do with how responsive you are. So obviously, as you give more anesthetic, you become less responsive to more and more intense stimuli. The need to manage the airway increases as you go from minimal sedation to general anesthesia. Your ability to breathe on your own is gradually ablated as you increase the dose of anesthetics, many of which blunt the respiratory reflexes that you have. And then your cardiovascular function is increased as you deepen the anesthetic as well. And so all of this to say that as you go into the realm of general anesthesia, which is necessary for some more invasive procedures, you tend to engender a stress on the patient's physiology, much of which is cardiopulmonary related. Not a lot is known about how one might perform, an anesthetic. And as pointed out, there are some guidelines and some suggestions as to what may be optimal. But ultimately, nobody has received an actual anesthetic in space. And so, as you can tell by these quotes, research needs to be done, in how to perform adequate surgery and anesthesia in these austere environments. So multiple anesthetic strategies are possible. General anesthesia is one in which you're rendered unconscious and you're fairly advanced in terms of your sliders and all of those aspects of the anesthetic state. You can administer local anesthesia where you essentially numb up a local area. This tends to be sort of for more superficial procedures, like if you have a laceration that's, in the skin rather than, deep procedures like doing an appendectomy. And then you can do epidural or nerve blocks, and we'll have a talk by one of our panelists that goes into this in more detail, where you can numb an entire limb region of the body and so forth by injecting of local anesthetic medications, often under ultrasound guidance, as you see an example of that here, as they are no doubt trying to fix this injury to the hand. The trade-offs of your choice of anesthesia. So as you go from regional to general anesthesia, the risks of the techniques tend to increase, primarily because the physiological stress engendered on a patient, especially those that have suffered some of the physiological derangements that Mike has already described in the microgravity environment, will impose more of a stress on the patient's body. As you go to regional anesthesia, less stress on the body, but requires much more training in order to be able to do some of these regional techniques and blocks, and we'll hear more about that later. So what you do for various procedures is going to sort of depend on how you manage this trade-off, which has to do with equipment and has to do with who you have on your crew and the training that they have and so forth. Typical types of surgeries have to do with traumas that you might receive in the or you might experience in the space environment. And so here's sort of a list here. As you can see, the suggested anesthesia for most of these on the list is general anesthesia, either breathing on your own or having to manage the airway. And we've already heard about the challenges of managing an airway. But within this, there's a subset of these, if you have the personnel with the training to do so, that could be done under regional anesthesia as a viable option, or regional anesthesia depending on the location. And these tend to be, injuries of the limbs or surface injuries that may be amenable to being able to numb up the area and so forth. So in terms of the types of drugs we're talking about, these are, as far as we do anesthesia here on Earth, the typical medications that we use to induce and maintain the anesthetic state. There's a whole class of those that are inhalational, and then a number of those that are intravenous. You give them through the IV, and this is when they were discovered. When we're talking about a spaceflight environment, we're really going to rule out a lot of the inhalational anesthetics because of equipment issues, right? The difficulty of delivering them, contamination of the closed environment with these anesthetic vapors, and also the fact that they are can be significantly cardiovascularly depressant and may not be the best choice. The physiological effects we've already gone through, so I'm going to kind of rush through this a little bit here. We've covered the effects on the cardiovascular system. A lot of the reflexes that our cardiovascular system has to maintain good circulation when we're in a full gravity environment end up being deranged when you're in microgravity. And then when you return from microgravity back to terrestrial environment, there's some time that it takes to adjust. You have that chicken man syndrome because all the fluid sort of accumulates in the upper half of your body because there's nothing to counteract the natural reflexes that do that against a gravity environment. You have effects on GI motility, effects on the immune function, and then neuromuscular deconditioning as well. All of this to say that in the worst case scenario, you want to prepare for a deconditioned, hypovolemic, anemic patient with cardiac and hemodynamic dysfunction, who's an aspiration risk and a difficult airway, being cared for by a minimally trained provider. That is a lot of challenges in a short sentence there. And so in terms of talking about some of the drugs, the intravenous ones are really the only ones we will consider here. Most of them, except for one in particular, work by a complicated mechanism, but a major part of that mechanism is by potentiating off switches within your nervous system. And this GABA, gamma-aminobutyric acid receptor, is a receptor in the central nervous system that, when it is engaged and agonized, basically increases depolarization of neuronal elements and tends to power down your nervous system. Ketamine is a notable exception, and we'll highlight that here at the end. As it turns out, barbiturates and propofol are not the ideal option, even though propofol is one of the most commonly used intravenous anesthetics here on Earth, because they are cardiovascularly and respiratory depressant. You could see this quote by Halford back in 1943 that due to the effects of barbiturates being cardiovascularly depressant, they are the ideal form of euthanasia and war surgery, not recommended. Propofol is one of the most hypotensive of all of the intravenous agents that we have, but also it needs to be stored in a liquid form, in a liquid emulsion, and has a limited shelf life, particularly after you open the bottle, and can only be given intravenously. Etomidate is another intravenous agent that we often use in trauma anesthesia. It has fewer effects on hemodynamics and respiration, but it does have other side effects, including suppression of your adrenal system. Nausea, vomiting is a limiting side effect. And again, the prospect of nausea and vomiting in the microgravity environment has already been talked about, and also can be very painful at the injection site. So that brings us to ketamine. Ketamine is a little distinct in the category because its major mechanism is different. It engages different receptor in the central nervous system, the NMDA receptors. It's hypnotic, in other words, can engender unconsciousness. It's amnestic, but it's also unique among the intravenous agents that it is analgesic as well. And oftentimes we use ketamine in the treatment of chronic pain syndromes as a result of that property. It tends to stimulate your cardiovascular system, tends to increase heart rate and blood pressure, unless you are, critically ill and are depleted in your store of catecholamines, tends to dilate your airways, engenders minimal respiratory depression, and it's also available in a powdered form that has 20 years of shelf life, so that makes it more attractive in terms of your equipment limitations. It can be given either intravenously or it can be given intramuscularly as well. So if you don't have vascular access, you have a route to be able to give it. It onsets very quickly in about a minute or so after you give a dose, and it has a high therapeutic index. So if you're providing anesthesia with a not highly trained provider, it's more safe in the case of potential overdose than would be some of the other agents as well. And so as a result, ketamine is on the WHO list of essential medications because of these properties. It does have some adverse effects, many of them which can be mitigated. Ketamine has this sort of dissociative effect on your psyche, where it can give you vivid nightmares. You can mitigate that to some degree by giving midazolam. You can see increases in intracranial pressure, which is relevant if you have head injuries and bleeding into the cranium. But it's found that that can also be mitigated by midazolam, and in patients with normal intracranial pressure, that's not clinically significant. It does increase secretions, which is problematic, as we've already heard about in the space environment, but there are medications that you can give that are anti-sialagogues that can sort of mitigate that, like glycopyrrolate. And so the last thing I want to talk about is the sort of neuromuscular deconditioning. So the neuromuscular junction, your muscles are activated by signals from neurons at the neuromuscular junction. The way that you provide paralysis during an anesthetic is you block those. We have two categories, non-depolarizing and depolarizing blockers. In other words, the non-depolarizing ones simply block the receptor and prevent the neuromuscular transmission. The depolarizing ones will activate them first, and then there will be a period of blockade as those receptors are refractory afterwards. Now, the issue with neuromuscular blockade is that we want to avoid the depolarizing ones because, as part of the normal physiology of those receptors, when they are activated, they pour potassium out into the circulation. And if you have too high potassium in your blood, that can be lethal to you. In fact, it can stop your heart. And so patients that are deconditioned oftentimes will upregulate some of these acetylcholine receptors. And so you can get a life-threatening hyperkalemia if you give succinylcholine. So that's one drug that you want to avoid if you need a paralytic. So in conclusion, data on humans receiving anesthesia in space is largely lacking. Optimal anesthetic techniques have to consider the level of provider training, the limitations of your equipment and environment, the physiological changes engendered by microgravity, the surgical procedure you want to perform, and the resource availability. Regional and general anesthetic techniques involve trade-offs that we talked about. Intravenous anesthetic techniques are really the only ones that are feasible in the space travel environment. Ketamine in combination with midazolam offers multiple advantages over the other intravenous agents and is probably what would be recommended in our current knowledge. And then you want to avoid succinylcholine if you need neuromuscular paralysis. And as always, future research is needed to refine some of the protocols that we would develop to provide anesthesia in space. So
thank you for that truly outstanding talk, Rob. Really, really fantastic. Next up, we've got Fayyaz Ahmed. He's an assistant professor of anesthesiology at the University of Chicago. He trained in Dubai as well as Pakistan for medical school and also did anesthesia training at Temple University in Philadelphia. He has skills in regional anesthesia and a special focus in orthopedic regional services. He believes in expanding the utilization of regional anesthesia for safer and effective anesthesia with better pain control. He's leading the resident education in regional anesthesia and expansion of the regional anesthesia program at the University of Chicago. And he's also written multiple book chapters and review articles. So thanks for sharing your expertise on regional anesthesia with us today.
Thank you for the opportunity. So my talk will be sort of an extension of the choice of anesthesia, which we have already discussed, and I will talk more about the regional anesthesia, which can be as an effective solution for some of the space medical procedures. And disclosures, no conflict of interest or relevant disclosures. In terms of objectives, we will firstly go over the benefits of utilizing the regional anesthesia in space, and then we will talk the process. If we think that regional anesthesia could be one of the essential anesthetics, how can we incorporate this into the space missions? And the third will be to discuss the common nerve blocks to facilitate the regional anesthesia program in space. So for the success of any spaceflight missions, it's increasingly threatened by emergency medical situations, and especially as missions venture further from their terrestrial medical support. And even though there has been decent amount of work done on the procedures being performed on the microgravity, there has been comparatively less attention has been given to their safe and effective anesthesia. So if we look at the possible injuries in the space missions, there has been identified around 84 injuries in the list, and out of which 17 of them require anesthesia. And so now when it comes to the planning of the anesthesia, we have to choose the one which is more feasible, appropriate, and effective in applying in a space mission. So the two big ones, which, as Rob mentioned as well, is we're talking about the two extremes. We're talking about the general anesthesia versus the regional anesthesia, and everyone touched on about the differences and how the physiological changes which occurs with the body in the microgravity. So even though general anesthesia is the go-to anesthesia for most of the procedure on the Earth, but when it comes to the space, it is more complex. There's more complexities involved, and there's more challenges when performing general anesthesia. So, however, when we talk about the regional anesthesia, which could be a way to overcome these obstacles to provide a safe anesthesia and provide prolonged pain relief. Okay, so now we just again, I think this was touched upon earlier, but I'll quickly go over through. General anesthesia, it's when it affects the whole body. It usually induces a loss of consciousness, which involve the changes in the body physiology, changes in the hemodynamics, cardiovascular, and the respiratory physiology. And almost always you require a breathing tube and a ventilator to help you breathe. And comparatively with regional anesthesia, it requires more space, more equipment, more skill set, and more support staff to administer general anesthesia. And it is, as mentioned, it is the go-to anesthesia for most of the major surgeries when it's done. But now when we talk about the regional anesthesia, it affects a specific part of the body, and it's a technique which takes away the sensation and the motor strength from a region of the body. And it actually consists of infiltrating the nerve with an anesthetic agent and blocking the transmission to avoid or relieve any pain. And comparatively from the general anesthesia, it requires less space, less equipment, and less skill set and less support with all this. So now, again, I think we touched over through this. I'll quickly go over through this. General, when it covers the whole body, induces loss of consciousness. Local is when it covers a specific area of the body, which can be infiltrated by local anesthetic, like when you go to the dentist. Now, the third one is what is the one which we'll be talking more about it, is the nerve block. And nerve block basically is the regional anesthesia, and it covers the affected limbs. It can be the upper extremity, can be the lower extremity, or it can be any region of the trunk or the hip. And I see it mentions their epidural anesthesia, but I would quickly like to mention here that doing an epidural anesthesia or doing a spinal anesthesia, it's very risky due to the unpredictable nature of the spread of the medication. And no studies has been done for that, how the spread of the medication behaves in microgravity. And I don't think so that would be a wise option to even consider that. So now when we think, we'll talk more about the regional anesthesia, how we can look at the details of it, the way which we can possibly incorporate the regional anesthesia. So the regional anesthesia, as we talked about it, it's mentioned, it's a technique which, it keeps the patients conscious. So that's like a huge advantage. It keeps the patient conscious, and the patient is able to protect the airway, which means the need to perform a potential difficult intubation is avoided, and it keeps the crew member awake and interactive during the whole process. But even though we see on the right, it's this image which shows that it's the minimal things what we need. We need an ultrasound, we need a needle, and we need medication to perform the regional anesthesia. Even though it offers simplicity over the general anesthesia, but for a successful regional anesthetic, it requires appropriate equipment and, most importantly, the right technical skills to implement when it's needed. So we'll talk a little bit more about the equipment and go over what can be done, what can be added, and what are the existing equipment available. First thing, the most essential equipment is an ultrasound. But the good news is the current available ultrasound, which exists for the space missions, can be utilized. We don't have to add something new. But the next tool, what I think can be a game changer and very effective in providing regional anesthesia is incorporating an AI-assisted module to the existing ultrasound. So what it does is when you place the ultrasound on a part of the body where you need to do the regional anesthesia, it identifies the anatomical structure and highlights it, making it much easier for the crew member to perform the procedure more safely, quicker, and easier as well. And monitoring, and we need to monitor the patient while doing this, and we can again utilize the existing basic vital sign monitor which exists there. And this thing, what I have labeled it as a nerve block box, is basically having a box with the where the things which we need to which we need for the regional anesthesia, having the syringes for the local anesthetic, and adding long and short acting local anesthetic depending on the need for the procedure, and adding Stimiplex needle to perform the block. And last but not the least, this would be one of the essential component to perform the block on a mission, is having like a nerve block checklist. And that would have the indications for the procedure, step-by-step directions for the procedure. And also it can also have like a reference scan of the anatomical structures of the crew members. So now moving toward the technical skills, and as mentioned earlier, one of the chief challenges to implement a regional anesthesia program will be the development of technical skills among the crew members. But I believe this hurdle can be effectively overcome by focused training tools and using AI-assisted technology like ScanNav, as I mentioned earlier. So the technical skills pre-mission on the Earth, let's talk about those things. So first thing and foremost is having proficiency in using the ultrasound. And in using the ultrasound, but I believe the current implementation of the ADUM protocol, which is the Advanced Diagnostic Ultrasound in Microgravity, has established like a basic familiarity of ultrasound among the crew members, and which can be profoundly helpful in providing foundation skills of using ultrasound for the regional anesthesia. And the second thing is mastering the common nerve blocks, which can address majority of the conditions. And so the first one, which I am mentioning here, is that for the upper extremity, we can do a nerve block for the brachial plexus, which is called as supraclavicular nerve blocks. And by doing that, it can cover most of the procedures to be done on the upper extremity. And the second one, for the lower extremity, we have two big nerves which supplies the lower extremity, among others, and which are the femoral and sciatic nerve block. And learning how to do the nerve blocks for these nerves can be essential to cover the lower extremity. The third one, which I have mentioned here for the hip and the truncal, these are the fascial plane blocks. I mean, these can be considered, but the point here is that with these blocks, it can help with superficial analgesia effect, but maybe not necessarily for providing any procedure on the hips and the trunks. So once we have highlighted, okay, these are the procedures which we need to master, the second thing is, what is the best way to do that? There are two things which can be implemented to do that. The first thing is doing an average of 20 procedures for each nerve block, as this is on average required to reach a learning curve plateau. And the second thing, which I believe can be very essential, is scanning the plant crew members. Because one of the challenges for doing regional anesthesia or doing a nerve block or even on earth is the anatomic variability between different individuals. So once you scan the anatomy of the crew members or plan to do, you gain familiarity with the anatomy, and also you can have reference scans which you can use if it comes to it. So this image just highlights how a supraclavicular nerve block for the upper extremity would be performed. This is an ultrasound placed just above the clavicle, and it looks on the right, this ultrasound image, which on the red curved lines, this is where the anesthetic medication will be injected, and it will cover the upper extremity. This is for the lower extremity. This is the femoral nerve block. This is done around the groin area. The same thing, we have to place the ultrasound, we need a needle, and identifying the structures and putting the medication around the nerve. Now, talking about the technical skills which we need to kind of implement on the space, the first thing is, how can we use the technical skills and perform an effective nerve block? So the first thing is utilizing the in-flight checklist, which had been created pre-mission, which has the guidelines and the step-by-step directions for the procedure. And the next thing is utilizing the reference scans, which we had been, imaged and created from the crew members, and this would help as familiarizing with anatomy and doing the procedure. And last but not the least, I think in a combination with the reference scan and using the AI-assisted tool, it can really help with identifying the structure and performing the nerve block if there's proper indication for it. This is how incorporating an AI-assisted tool will look like. On the left side is the raw ultrasound image, and on the right side, when it's connected with just like an SDMI cable and a module of the AI technology, what it does is identifies the structure and color highlights it, and then it shows something like this. When you see it identifies structure, labels it, and knows how exactly to do, and it gives the next direction as well. So just as application, since we talked about all this, we'll just go over through the application again. So I believe regional anesthesia can effectively address the challenges of managing emergency medical situations and with anesthesia during prolonged deep space flight missions. And its relatively safe and effective characteristics make it a viable option for a wide range of emergency medical issues. Most importantly, I think the patient can remain awake and alert and can continue providing expertise and even return to the mission task much more quicker because the patient is not sedated and is conscious. And it can be applied for injuries like burns, cellulitis, elbow shoulder dislocations, upper and lower extremity fractures, and skin lacerations. And just the last one more thing which I need to mention is, having there's one more side effect which we need to be aware for doing nerve block is having local anesthetic toxicity, which we need to be consider and keep that in mind. These are my references, and thank you for the opportunity.
Thank you for that truly outstanding talk. What an amazing idea to do reference scans prior to the space mission of all crew members and passengers, and also to have people practice scanning each other ahead of time. I think that'll be truly useful for upcoming space missions, and outstanding talk, all of it. We next have Arthur Formanek. He's a staff anesthesiologist and intensivist at Brigham and Women's Hospital and an instructor in anesthesiology at Harvard Medical School. He completed medical school at the University of Arkansas, as well as residency at the University of Maryland, critical care and thoracic surgery anesthesiology fellowships at Brigham and Women's Hospital. He has authored chapters and spoken nationally on regional anesthetic techniques for neurosurgery. His research interests include the intersection of perioperative and intensive care with spaceflight and ventilation strategies in ARDS. Dr. Formanek has been recognized by his department with an award in excellence and has been awarded Attending of the Year by the residents. He's Associate Director of the Thoracic Anesthesiology Fellowship, and he has a strong interest in aerospace medicine, currently developing transfusion methods for use in spaceflight, and has patented an IV air trap designed to work in microgravity that will allow rapid transfusion in spaceflight and austere environments. He's worked on other projects with NASA, including increased post-void residuals in spaceflight and risk of urosepsis. He is the current president of the Space Surgery Association, which he also co-founded within the Aerospace Medical Association, and is an associate fellow of the Aerospace Medical Association. He's also a major in the US Civil Air Patrol. So he'll be speaking today about air embolus.
Thank you, Dr. Clebone Ruskin, for the very kind introduction. So today we'll be talking about prevention of air emboli, and I have no financial relationships to disclose. And so when I tell people that I am working on means of administering IV fluids in space, usually the most common response I get is, oh yeah, it'd be difficult with no gravity pulling the IV fluid down the tubing. And that problem is actually a little easier to fix. You either put on a pump or on a pressure bag, or even hand bolus it. It's the other things that sort of don't come to mind immediately, are sort of the more insidious and difficult things to address. And so thank you, Dr. Fong, for touching on the pharmacokinetics. And then I'll be talking about elimination of air. So Dr. O'Connor, thank you for introducing this photo before, because I think it perfectly illustrates the problem of air in IV fluids in space. So we are quite spoiled with having gravity remove or separate the two dense solutions of pulling the fluid down, letting the air float to the top. Well, it's not going to work in space. So instead, if you take a bag of IV fluid, it turns into this foamy type consistency, and it's devilishly hard to get it out of the bag once it's in there. So why don't we just de-air the bag on Earth? So unfortunately, there's some problems with that. So if you introduce any air in flight, then you're sort of hosed. And NASA does have this problem with the space station with coolant. So since some of the coolant access points are in the environment, if you introduce any air, it's hard to get it out. And so similar type of thing, if you introduce any air into medical fluid, you're going to have a problem. Also, making the bag completely impermeable to air is hard. So I'm sure we've all opened a bag of crystalloid, and in between the inner and outer bag, there's moisture, and that's because water vapor actually went through the inner bag. So it's very hard to actually make something completely impermeable to air. And then also, dissolved gas can outgas if you change the pressure or the temperature of the fluid. And this is the reason why we always have air traps distal to a blood warmer. And then also, if we hang a medication that has been in the refrigerator on a pump, about 30 minutes, the pump's going to start alarming and driving my residents nuts, because the bag or the fluid is actually outgassing, and the IV pump is catching the bubbles. So why is this a problem? The lungs are actually a pretty good means of removing air out of our circulation. And it can take about 50 milliliters of air before you got a problem. But eventually you can shed air into the arterial side, and you can also airlock the right heart. We're particularly concerned about this in neurosurgeries, when we can get negative pressure around the skull and actually get air sucking into the venous circulation. The way to fix this is supportive therapy with pressors, namely epinephrine. Stop the insult, so stop the way the air is getting into the blood, and then position them. The goal of positioning is to get the air bubble to move forward through the heart into the pulmonary circulation. The problem with that is it's gravity dependent, so that's obviously not going to work in a microgravity environment. And then also, if you have a Benegan-Albin catheter, also known as the multi-orifice catheter, in place, you can try and aspirate the air bubble out. If you want to start a fight amongst neuroanesthesiologists, talk about the utility in having this in. It's rather divisive. So whether this would work in a microgravity environment is truly an unknown. So if you do get a right to left shunt and shed air into your arterial system, the treatment for that is purely supportive as well, namely hyperbaric oxygen. How does that happen? You can either give a large amount of air and exceed the ability of the lungs to clear it, or you can have connection from the right to the left side, namely a patent foramen valley. It's just a congenital defect that is present between your atria. And it's actually remarkably common. So if you do autopsies, more than a quarter of people will actually have one present. But in order for it to be relevant, it has to be there both anatomically and functionally. So normally our higher left-sided pressures will actually hold that PFO shut, and it's not a problem. Unfortunately, though, if you do have a PFO, it does certainly increase your risk for air emboli. And so if we do have an echo showing that we have a patient terrestrially who has a PFO, we're very careful about introducing any sort of air into the venous system. And then also divers have an increased risk of DCI if they do have a PFO. So how do we get rid of the air? Unfortunately, there's not a whole lot of great ways to do it without gravity. So for instance, you take a vial of intramuscular or IV medication. If you take it into space, they all look full because the air bubble moves to send to the container and the fluid is sort of pulled outward. So an engineering team in Texas A&M University has developed this specialized vial that uses capillary action to remove or to preferentially pull the fluid out without removing air with it. This is a picture just from a press release. So far, this has not gone to publication yet. We do have some good means to remove air with out of IV fluid as long as it's not blood or rapid transfusion. So this is an inline filter. I'd call them PFO filters because we put them on our patients who have PFOs. It uses a hydrophobic membrane filter to allow gas to pass out through the filter and vent into the atmosphere and does not allow fluid to pass. So these are fantastic. The only problem is they don't work with blood, or they're incompatible with blood rather, and they don't work with high flow. You can easily overcome it. So just to show how this thing works, so I'm just giving an air bolus slowly, and you can see it's very nice and no air exits out of the patient side of the filter. However, if you push a rapid bolus through, you can see all sorts of air bubbles are passing through. So how do we overcome this? You can either put an air sensor on that shuts down the flow, but then you're just shutting down the flow, you're not actually removing the air, or you can actually have several different systems that that are compatible with high flow. Unfortunately, they're all gravity driven at this point. This is off a Ranger high flow, and I absolutely love it because it's so eloquent the way this thing works. So you can see I'm injecting some fluid and air. It goes into this air trap that allows the bubble to float to the top, and then the air bubble is vented out of the atmosphere via this hydrophobic membrane filter. It's very elegant, works, passively driven, very reliable. Unfortunately, gravity driven. However, what if we take this hydrophobic membrane filter and wrap it around a spindle, and then we take fluid, allow it to flow in, spin around this cylindrical chamber, and then exit? So then you're sort of creating a passively driven centrifuge, and the more dense fluid is getting forced to the outside of the housing, less dense air is forced against this membrane filter and is venting into the atmosphere. And that's the design philosophy of a membrane hydrophobic membrane filter that we're currently in development. It's currently in development. This is the second generation of it. It's the same philosophy. The only thing is we've added some baffles into it to increase the number of turns, and we've created we've added a latex membrane to decrease the amount of dead space within the system. Taking the filter apart, you can see this latex membrane on the outside of this hydrophobic membrane filter with the baffles around it. Air goes in, air and fluid rather goes in through the inlet port, goes around, and then it's vented. The air is vented out the side, and the de-aired solution is then administered to the patient. We use additive manufacturing, more commonly known as 3D printing, to create the baffles, the housing, and the inner core. Unfortunately, there's really no good way to 3D print a hydrophobic membrane filter. So we applied that post-printing as well as the latex membrane on the outside of it. We tested it with the tested against the currently available inline filters, and we even put 3 in series, in parallel, to decrease the amount of resistance and increase the amount of flow through it. We spiked a bag of crystalloid and let it flow through and measured the time it took to empty a bag of crystalloid at just held at gravity, and then also to at 150 millimeters of mercury and 300 millimeters of mercury. And then we also measured the efficiency of the filter in removing the amount of air that was injected, and it works pretty well. So looking at the resistance within the filter, control has no filters in it whatsoever, so this is just free flowing. Our newest iteration has a minimal more resistance than having no filter in it at all. And certainly having your standard one commercial filter in there will decrease your flow quite a bit. And in terms of efficiency in air removal, this graph helps explain how this is working in the first place. So with our first generation, as the flow rate increases, it actually becomes more efficient because fluid is more rapidly going through that cylinder. Once we go to our baffled filter, again, it performs quite well, much better than what is currently available on the market. In addition, none of the commercial filters that we tested were compatible with blood. Now, having said that, it is really hard to remove any sort or all of the air that is going through, especially at high flow. And looking at a study looking at current high flow systems, generally some air does end up on the patient side of the filter. In terms of benefits from what we're currently developing, it's a passive, simple system. It's lightweight. It's easily flown. Some parts may be produced in flight. Now, having said that, some parts can't be, so assembling in flight could be a problem. And it very efficiently removes air. Problems, as hinted at before, while it is technically, or parts of it are, or could be manufactured in orbit, a high flow filtering device would not be something that you would want to sit around and wait to print. If you needed it, you probably needed it now, unless you were planning for some sort of surgery. But usually if you're in a trauma situation, you can't sit around and wait for it to print. And we're also just working on tolerances and general design, getting the thing to perform as expected. In terms of de-airing IV medications and fluids in general, so first of all, we need to understand a lot more about what is happening physiologically in space. Can you airlock the right heart in space? Probably, but we don't know for sure. And then also we do need to optimize the current devices that are in in the research pipeline to get them to to market into a point where they could be used clinically. All right, thank you.
Thank you so much for that outstanding talk. I really learned a lot, and I hope to see your device on future space missions. How fantastic.
Thank you.
Thank you so much for joining us. So next I'll speak just a little bit about vascular access, and then hopefully we'll leave some time for questions. Also wanted to mention the chat is been quite active with lots of wonderful questions and answers. So feel free to check that out as well, or type in more questions there as well. So today I'll talk about vascular access in deep space. Just book and article disclosures, talking about intravenous lines. I know we have an audience with a broad range of backgrounds. So as my colleagues have talked about, we would use an intravenous line to administer fluid for dehydration, medications, as well as even potentially blood in space in trauma situations. And this is one way of placing an intravenous line, which is using an ultrasound. And since hopefully there will be an ultrasound on the mission for other things as well, such as diagnostics and regional anesthesia for difficult intravenous access, an ultrasound may also be an option. So many medications you can't give orally. You wouldn't want to give intramuscularly. You need them to act too quickly, or they're not available in these other routes. Often many life-saving medications, especially in an acute situation where you might need anesthesia and surgery in space, you would want that intravenous line available. Also, some of my colleagues talked about the possible adverse effects of anesthesia, even regional anesthesia, which uses local anesthetic. You may, there's the possibility for something called local anesthetic systemic toxicity, and you would need an intravenous line in place to give life-saving medications in that situation. First IV in space was 1993 in the Columbia mission. They were looking at fluid shifts in space for research. It was not for patient care, but it was for research. As my colleague mentioned, the IV drip is dependent on gravity. So you're going to need to push in the fluids, or you might need a pump, which gives an additional risk for infiltration, which is when the IV is no longer in the vein and pumping fluid or medications into the surrounding tissues, which is typically only unpleasant if it's caught early, but certain medications, or if it's not caught early, can definitely cause tissue necrosis and cause that secondary problem. IV fluids, of course, must be sterile, but fluids are very heavy. It's limited in quantity, what you can carry to space. They could become contaminated. They have a limited shelf life, really a problem on these longer missions. Air embolus was touched on extensively, but just for a kind of a pop culture reference point, a can of soda is what it would take to cause a fatality. So the same amount of air that would be contained in a can of soda would be fatal if it was intravenous. Not in without gravity, lots of bubbles there in the fluids. So one possible way to solve these problems would be to actually generate the sterile IV fluid. And this is a NASA project. This device removes the air, bacterial contaminants, particulates, and heavy metals, and sterilizing filter. This filter must work without gravity, of course. So this is kind of the wave of the future in terms of one option for creating these conditions for IV fluids in space. So it will be exciting to see what is actually used on the mission, and was very excited to hear about all the ideas presented today. So I will open this up to the audience for questions. Thanks so much to all of our fantastic speakers, and thanks to Rana for inviting us.
Thank you so much, Anna, and to all the team for absolutely wonderful and informative presentations. Really, really great, and we're really honoured to have you with us today. A really great start to the day's event. And there have been a few questions in the chat, so let's see what there might be there still to answer. Or if anyone would like to unmute and ask a question directly to the panel, please go ahead.
Anna, would it make sense for astronauts to have implanted IV access for the duration of a case? Should they all get like some sort of a portacath?
I think the infection risk would definitely be too high. It's already a risk with current technology. And given that you're in an environment where you have limited access to antibiotics, limited access to treatments and critical care support should someone develop a bad infection. But there aren't I don't have the numbers on that. So you might know how likely an infection is from a portacath before it's accessed. I don't know if we have data on that.
So the devices themselves are not being asked, it's very low.
Okay. Go ahead.
So I was going to make one comment, and that is that I was giving this talk one time, a talk on microgravity physiology one time at an anesthesia meeting, and one of the participants was an astronaut who'd flown 3 missions on the space station. So always be nice to everyone in your audience, number one. But number two, when he actually raised a very interesting point, because I talked about bubbles in the fluid. And he said that they informally on the space station had just taken the bags and rotated them around like this, and were able to get enough centrifugal force to get all the air at the top where they could then aspirate it with a syringe. So you would at least have a head start as well with evacuating bubbles from an IV. And apparently they tried this a number of times and it worked.
Great question though, Michael. I also wonder about the potential for vascular damage with the portacath placements, especially so far we've sent very healthy people up to space. The next panel actually talks about medical considerations for commercial space flight, which will include space tourism and also more scientists going up to space or other commercial applications. So that'll be really interesting as we have humans who are not in physiologically optimal condition going up to space.
It's funny, Drew Gaffney, who's a cardiologist at Vanderbilt, actually took off in the shuttle with the long line CVP in his antecubital fossa as part of an experiment. Suha from Adelaide wants to know if there's much known about the potential radiation impacts on medications and anesthetics. Well, people are very concerned about just the vulnerability of the crew in flight to Mars to radiation.
For sure. And also, it's thought to be that a pregnancy would be unlikely to be viable in due to the radiation.
And Kaylin had a question about when we talk about stabilizing the patient. Some interesting problems there are that number one, as you mentioned, stabilizing a patient in space is not the same thing as stabilizing them on Earth. Here you can get them to a higher level of care in minutes to hours. If you're on a long duration space flight to Mars, you've got to manage the problem there. So question number one is, what kinds of things can you treat? And within that comes a fascinating ethical question, which is that if somebody's a crew member on a long duration space mission, they have some critical role to fill. So even though I may be relying on Anna to take out my appendix, I might want a surgeon to take out if I'm on Earth. But do I have the right to say no to having her take out my appendix if something happens to me and I can't fulfill my part of the mission? So a lot of these questions remain unanswered. We need more research.
And then Adrienne also had her hand raised. Thank you for all the outstanding questions, Adrienne.
Yeah, it's a fascinating topic. I'm not a medical person, so I'm coming at this from a different perspective as more of a space communications person. But I was curious, how does the gravity on the moon or Mars and Mars, how would that affect the usage of anesthesia? So there you're not talking about microgravity or zero gravity, but you're talking about lessened gravity. So I'm wondering what impact that would have, or would you have to create some sort of Earth gravity facility on the moon or Mars?
There has been some people have started to look at that, and it's actually even more complex than that.
Annie, you muted. Keith was using your microphone.
Sorry, Keith was using my microphone.
Yes, I'm using Anna's microphone.
I did not realize.
But so you'd be working on 0.38 GZ. The problem is when you've gotten to Mars, you've already been in microgravity for a year. So everyone there is debilitated. When they get there is debilitated. Now, when you land on Earth after spending a year on the space station, you go to extensive rehab to get you back to the point where you can work in gravity. And there's not going to be any rehab there. So there are other questions we answered there. So in addition to how this equipment works in microgravity, reduced gravity, you also have to consider the physiology is changing very rapidly at that point.
So then could the moon be used as a testing base or a testing ground for some of that? And I mean, it's a lot further and it's different gravity on Mars, but could the moon be a testing place for further deep space missions?
Yeah, and that's actually part of NASA's project with HALO to create a lunar outpost to do some of these studies. And even the International Space Station is a testing ground to see the effects of long duration spaceflight on people. So yes, we're doing that now with the ISS, and we're going to be doing that on the moon as well.
Great, thank you.
I think we have time for one more question.
Hi there. Sorry, just a quick question. Thank you so much for the great presentations. I was just wondering, in terms of the anesthesia, especially, so how far is cryosleep as well, in terms of a valid way of kind of hibernating the astronauts through space?
What type of sleep did you say?
Cryosleep.
Oh gosh, I don't know anything about it. Does anyone on the panel know about cryosleep? So do you mean just decreasing the temperature as a means of causing sedation?
Yeah, just sort of hibernating for extended durations, especially. Just read somewhere that they were doing some research with grizzly bears or brown bears when they hibernate, whichever one still hibernate. Sorry.
I don't think they've ever woken somebody up from cryo, not a human.
Yeah, right.
The University of Maryland Shock Trauma was doing a study, maybe 5 years ago, with cooling the patients off and during a trauma surgery with massive blood loss, transfusing them with crystalloids with saline, and then trying to convert back to blood and awaken them. I don't know if anything was published from that. I know that the outcomes were not good. Of course, there's some bias in the sense that the patients getting this are by definition bleeding out and have very, very poor outcome. But I don't recall anything published from that, which is not a good sign. Interesting concept, but unfortunately nothing I know of yet.
There is research. I was at a NASA workshop about 5 years ago now, looking at shallow metabolic depression for long duration spaceflight, and there is ongoing research. The point of this workshop was to ask the questions that would then drive the research, but the idea being that the gene for hibernation is distributed among a wide variety of mammals. Mice have it, lemurs have it, bears have it. A host of animals hibernate, usually in response to either temperature extremes or lack of resources. As humans, we haven't needed to hibernate because if we don't have resources, we just go somewhere else. But the thought behind this is that we may very well have these genes, they're just turned off. And so the point of this workshop was to start asking questions to drive the research to see if we could find some of these genes.
Oh, fantastic. Well, thank you so much for all of those really interesting answers and amazing talks.